Alright guys, this is Dr.Hwd and we are going to start our day one of the cardiovascular system. Okay, now the thing is that on the day one of the plab 2, I want you to make sure that you understand the cardiovascular system. Now you see, when you think of the cardiovascular system or the things that are related to the cardiac problems, you have to think of the things from outside to in, right? Like the symptoms that they could come up with are as follows, or the condition that they could come up are as follows. Think of the skin. All right, now this is a person. Let's make a stick figure here. I hope I can make one. So this is a stick figure that I'm making. Now the first thing that this stick figure has on the outside is skin, and the things related to the skin and the cardiovascular system the person could come up with, or the chest pain, which could be the first symptom that I'm talking about in the cardiovascular system, is the chest pain. So think of the stick figure, and the thing that one has outside is the skin. With the skin, you are going to think of herpes zoster or zoster, whatever you call it. That's your first thing. After the skin come the bone and the muscles. So in the bones and the muscles, you have to think of number one, trauma. Trauma could be a reason of chest pain. Yeah, that could be the reason of the chest pain. Or costochondritis. Again, the same thing, that there is an inflammation or the pain of this of the bones, right? So that is number one, herpes zoster. Then is your costochondritis or trauma. Then you think of the person's heart. I hope it looks like a heart because I really tried to make one. I'm very bad at making those. So heart. In heart, you're going to think of what? You're going to think of MI. Right? What is so different about the chest pain of the MI? See, the chest pain of herpes zoster, he's going to have some rashes, maybe some things related to it. The chest pain of the trauma is going to be movement associated, right? The patient would move forward, maybe they'd touch themselves, they'd have pain. That's the same with the chest pain of the costochondritis. However, with an MI, what are the distinct features? Number one, the radiation. The radiation of the chest pain of MI could be to the jaw, it could be to the abdomen, right? It could be even to the arm, right? That is your MI. Then the second thing when you think of in the MI is the family history. Their family history would be positive for that, all right? Apart from that, they would have a history of, being immobile, where their DASA that we talked about in day one, the diet, the exercise, the smoking, and the alcohol, they'll be positive. Maybe they're having a diet which is full of fatty stuff. Maybe it's a diet where, they are not eating healthy. Maybe they do not exercise. Maybe they're a smoker. Maybe they're alcoholic. All of these features are associated with an MI. A family history which is positive is also associated with an MI. So these are the things that you're supposed to definitely think of when you're thinking of a person who's got an MI, right? So these are the positive features, and the pain is going to be very, very severe. However, if the person's got diabetes mellitus, then the pain is not as severe as we can think of. All right, so that is your heart. After the heart, right, there is a membrane which is surrounding the heart. So if there is an inflammation of the membrane, what would happen? Pericarditis. Now, how do you differentiate pericarditis from that of the MI or anything else that we've discussed so far? Well, in the pericarditis, a person is going to have, because it has got itis, then you think of an inflammation. When you think of inflammation, you think fever. The patient's going to have fever. And the feature for pericarditis is that the pain is relieved when they move forwards, right? When they bend forwards or they try and pick up stuff, they say, it gets better. So you have to think of those things when you're thinking of pericarditis in a person who's coming with chest pain. Then, stable angina, where the, patient is going to be saying that, doctor, you know what? It's there for a while, then it goes away. So it's just like coming and going kind of a pain. But it's associated with, again, movement, strenuous exercises. That's very important for you to understand, all right? But they would not be in pain when they would come to you, right? So we're going to talk about that in a bit, okay? We're going to talk about that in a bit. The second, the fourth or fifth thing is your aortic dissection. Now, aortic dissection, that is also a very severe pain, right? The person's going to come up with chest pain. You're definitely going to ask them for Socrates, right? Because that's what you do when you're trying to ask history of pain, right? Do you guys remember that when you ask in history of pains, you use Socrates? Okay, when you're talking about the history of anything else other than pain, you use Odipara. And when you're talking of any discharge coming from any part of the body, you use the mnemonic tract. all right? Okay, so here's the thing about your aortic dissection. Now, a person would have chest pain. Along with that, they would have pain in between their shoulders, right? I know these are not very good scapula that are made, right? I hope this looks like one. I mean, just think about it. This person's are these arms, and he's going to have pain in here, right? He's going to have pain in this area. Okay, he's going to have pain in this area. So he's going to say, the doctor, you know what, I'm having chest pain. But apart from, and when you ask about the radiation of the pain, they'll say, well, doctor, you know, this pain goes to the back of my chest. Okay, that is really important for you to understand, right? Like the back of the shoulder blades, all right? That is your aortic dissection. Now, now you see, we talked about this stickman. Let's welcome the stickman again. So first is the skin, where we think of herpes zoster, because in that the person is going to definitely have a history of chest infection, a history of rash. He's going to have rash on his body, and he's going to say, well, you know what, doctor, the shirt that I wear or the clothes that I wear, whenever they touch my skin, it hurts. Okay, that's your herpes zoster. Then we talked about trauma, costochondritis, right? So we talked of costochondritis or trauma. In those, what happens is that the person would definitely be saying that, you know, the pain is associated with the movement. Right, it's associated with the movement. Then we talk of pericarditis, where the person would come with fever, and you know they would say that the pain is better when they when they move forward, when they bend forward. Then there's stable angina that we spoke of, which happens when the person is, you know, like he's moving, he's doing strenuous exercises, etc. Then aortic dissection, where the pain is in between the shoulders. So you're thinking of all these DDs when you're taking history of a patient who comes in with chest pain. After that, what else is associated in this stick figure? So skin, we spoke of the heart, we spoke of the bones and the muscles, then talk about lungs. I hope I can make a good pair here. All right, these are the lungs. Okay, these are the lungs. Now in lungs, you can think of 3 P's. All right, let's think of 3 P's. I mean, it's pneumonia, that's number 1, right? So there is, let's just change this pen color, pneumonia, right? So if a person's coming with pneumonia, they're going to have fever, they're going to have cough, they're going to have sputum. If you remember, in your school, in your med school, you always spoke of pneumonia, and you said that, you know, this is a primary thing. There should be fever, there should be cough, there should be sputum. Fever, cough, sputum. That is your pneumonia. Then the pulmonary embolism. The pulmonary embolism, the main thing in pulmonary embolism, which is associated with the lungs, which is the second P in the pulmonary embolism, is what? Very important. Travel history. All right, we're going to go over this in a bit. Travel history. Then a recent surgery, or, you know, like the person's going to have tenderness in his or he's going to have something associated with the DVT, right? You know what a DVT is. He's got venous thrombosis in his legs, and he's going to have leg pain, right? So leg pain can also be there in a person who comes in with chest pain. So you have to ask travel history, like a long haul flight, or chest pain, right? Chest pain is definitely the main symptom. And then cough, muscle tenderness. After that, the third P in your 3 Ps is pleuritis, right? Again, the pain is there, right? Chest pain is there, there's cough, and there is, it's associated with movement. And then is pneumothorax, right? Pneumothorax is also a part of a person coming with chest pain, right? A severe, short, stabbing kind of chest pain associated with, again, what? Trauma or accident. So what do we learn here? We learn here that there are lots of DDs that a person could come up with, but if you have this stick figure in your head, where you go from out to in, which is skin, bones, muscles, and then when you get in to the lungs and the heart, you get to know the DDs, all right? Now, I told you that, you know, any person, anytime, these are very universal kind of mnemonics for the sign and symptoms a person comes with. That is your P1, right? Like the presenting complaint, P1. So for P1, if person's coming with chest pain, we've got Socrates, okay? And if the person's coming with anything else other than the pain, that is Odipara, okay? Or Odipera, whatever you want to call it. And then if a person's coming with discharge, then it's Trach. So let's talk about pain, and let's talk about Socrates. In Socrates, we've got site, onset, character, radiation, associated factors, right? And then at time, how long it has been for, and relieving factors, and severity of the pain. Severity is really, really, really important, all right? So think about it. site is chest pain, all right, we're going to ask them, can you point it with one finger where it is? Then the patient's going to be like, no doctor, it's all over the place. Maybe you were thinking of what? You were thinking of MI, you were thinking of pericarditis, things like that, right? The character is also important. You have to ask one more thing here. Are you in pain right now? So let's get to the history part of our chest pain. Okay, this is plab 2, day 1. I'm reminding this is Dr.Hwd. Okay, I hope you guys can hear me properly. All right, so the first thing is, whenever the person comes up with any kind of pain, anything at all, the first thing for you to do is what? Greet. Good morning, good afternoon, all right, this is doctor this and this. In your real exam, you're also going to say your GMC number, right? You're also going to talk about your GMC number in your real exam. Now, that is your introduction. You introduce yourself, you confirm their identity, then they're going to be like, you're going to be like saying, all right, good morning, may I know what brought you here, or how are you doing today, may I know what is your concern, or you'd be saying that what brings you here today. The patient would be like, doctor, I've got pain. Then you'd be like, all right, may I know a little bit more about that? You might want to show sympathy and empathy there in your voice. You'd be like, all right, I can see that is troublesome. Thank you for coming in. You did the right choice, or you made the right choice. So where is the pain exactly? Like, can you tell me? Now, most of us, what we do, we go along and we say, where is the pain exactly? Right? We say, where is the pain exactly? How about you say and ask an open question instead of a closed question, as you see here? How about you ask an open question and say, could you tell me a little bit about this pain? Or can you tell me a little bit more about this pain, or tell me more, or can you elaborate it? Any words that you choose, but please make sure it's open-ended question. After that, when they say everything, then you'd be moving to your Socrates. But before that, they told you everything about their pain, then say, I'm sorry to hear about that. Are you in pain right now? The patient's going to be like, yes or no. Then you need to ask them, right? So you need to explore in the first 2 minutes, that is 120 seconds. You have to definitely come up with the diagnosis, because by then you are done with your Socrates, you're done with your DDs, right? Differential diagnosis, the questions that are related to that, and by that time you should come to your diagnosis. So you take the consent, right? And then you ask questions. Then you ask them, are you in pain at the moment? Right? Are you in pain at the moment? Are you in pain at the moment? Right? Your ATM, are you in the pain at the moment? Right? That is very important. After he says yes or no, what do? You scale the pain. You grade the pain. At the moment, score it. Can you score it on a scale of 1 to 10? He says it's 7. You're going to be like, I'm sorry, that is really, really bad. Gosh, that's really bad. Are you comfortable enough to talk? The patient's like, yes or no, whatever the answer is, and you reply accordingly. Now, the thing is that if the patient says yes, then you're going to be like, all right, I hope you can bear with me. I'm going to try and make it quicker, because it's chest pain, guys. He's dying, right? You're going to be saying, I'm trying to make it quicker. However, if you feel like you're very uncomfortable, let me know, right? The patient says, no, I want pain medication. Now, here is the thing about pain medication. For example, the patients come up with pain medications, right? Like, he needs a pain medication, all right? So you say, all right, I can give you the pain medication, but the thing is, if you give him the pain medication right now, what would happen? If you give him the pain medication right now, it would mask his pain. And when you do examination of your, especially of the abdomen, this is for abdomen, by the way, then you wouldn't know exactly where the site is. But if the patient's got chest pain, you might want to consider giving him pen medication, and to ask them about if they're allergic to anything. This is very important. All right. So that is the first thing about the pain, right? So you got to know about the pain, you discovered pain, you did the Socrates, and now you're moving forward, right? You did your P1. You did your Socrates, you asked everything. By this time of P1, you should come up with a diagnosis, a tentative diagnosis. All right, a tentative diagnosis, where you're going to ask them that, then after you've come up with a tentative diagnosis, the second thing is for you to ask about these major things. Cough, is he having any cough? Because I told you, after the chest, in the chest we've got what? We've got the skin, right? So for skin, you might be asking about, any rash or so. However, after the heart, right, we asked about the lungs. So in the lungs, a person can come up with cough, right? Cough, fever, shortness of breath. You have to ask, are you experiencing any cough? Are you experiencing any fever? Are you experiencing any shortness of breath? Now, this is after you've asked your P1, right? After you've asked your P1, you have to definitely explore these. Shortness of breath, palpitation, right? Trauma. That's also very important. Trauma, all right? So in all this scenario of a person coming with chest pain, you started off by, good morning, this is Dr. blah, blah, blah. I'm one of the junior doctors here. May I please confirm your name and age? The patient's like, yes, please go ahead. You ask that, you confirm that. The patient says, I've got chest pain. Then you say, I'm sorry to hear that. That is distressful. Can you tell me more? Or can you elaborate it? Can you tell me about this chest pain? The patient says, yo, this is what happened, right, doctor? This has all happened. Then you try and do your Socrates. All right, after you're done with your Socrates, then you ask them that, are you having pain right now? You do the scoring. Then depending on the response, you give them the pain meds or so. Then you come up and move to your DDs, right? In your DDs, you can start asking, do you have cough? Do you have fever? Do you have shortness of breath? Do you have palpitations? All right, can you feel your heart racing? Can you feel your heart racing? That's very important. Then trauma, okay? After you're done with that, you should go for the stick man. Think of the stick man and try and exclude those things. Is there anything associated with the skin, right? Is he having any trauma? Is there any trauma with his head, with his chest or so? Then you think about the heart. You ask questions related to EMA. You ask questions related to pericarditis. You ask questions related to your aortic dissection, your stable angina, all right, or angina, whatever you want to call it. I think I said the same thing twice, all right? Then you think of the lungs. I hope I make a good picture again, because that was a miracle. Okay, I'm not very good at that. Okay, so you think of the lungs and you ask questions. This is not a very good lung. Okay, you think of the lungs and you ask questions related to that, like fever, cough, sputum, because you're thinking pneumonia. I'm repeating those things, right? Pneumonia. Then you ask pulmonary embolism questions. Travel history is very, very important there. We'll talk about how to go in there. Okay, so this is what you ask questions related to. But you see, you have to not ask almost everything, right? Because you're going to be like, Dr. Hwd, we've just got 8 minutes. How do I do this? Very important, right? So this is why I ask you to go for open questions in the beginning. Because if you go for open questions in the beginning, what happens is that, you don't beat around the bush, right? You ask for an open question, you know this person's taking you in one direction, and you follow that and you answer accordingly. Then you do your DDs depending on where the patient said things are. You have to just maybe exclude 3 to 4 DDs, not more than that, please. Not more than that, because you're going to waste your time, right? You're going to waste your time, right? Okay, 3 to 4 DDs. After that, in all the scenarios, right? Concern, differential. Out of these 3 to 4 DDs, go for flaws, which is very important, which is what? Fever. Because this is GMC or NHS is trying to see that you've done your plab 1, right? They say, guys, you've done your plab 1, right? You've done your plab 1. The second thing we're doing right now is plab 2. They want to see 2 things in plab 2. Number 1, are you a safe doctor? Look at me, I drew a big S here, right? So S, are you safe doctor? Because they know you are a good doctor. They know you are a good doctor. Now they want to see, are you a safe doctor, right? So if you are a safe doctor, you would make sure that you exclude the sinister things. Please, guys, focus on this word, sinister things. Cancer is sinister, right? Okay, so this is related to cancer symptoms, right? Flaws, which is going to be, see, you forget almost everything. You forget everything in your exam, but if you remember to explore the presenting complaint, which is P1, if you explore the P1, and if you in your head have got some DDs, you do that. If you remember the structure, and then you ask for flaws and trauma, most likely you have the answer to what is the person suffering from or has. Secondly, please don't use the word suffering. I just use this here as an example. Never use word suffering. Okay. Fever, lethargy, appetite loss. Are you having any lethargy? Do you feel lethargic? Do you have any loss of energy? Weight loss. Now, weight loss with W is unintentional weight loss, because remember, there are people who are trying to lose weight. All right, so you have to ask them, are you losing weight without any intention of losing weight? Then you have to ask about fever, lethargy, appetite, weight loss, and swelling. Are you having any lumps and bumps in your bodies? In your body anyway, not bodies, body, right? So fever, lethargy, appetite loss, weight loss, unintentional, and swelling anywhere in the body, right? This is where you're trying to show them that you are a real doctor and you're very concerned about them. After your P1, right? After your P1 comes your P2. Okay, after your P1 comes P2, which is the second thing in our structure, all right? This is the second thing in our structure, P2, okay? In the P2, what do we have to discover? We have to ask them, past medical history of P1. Right, so they're coming with chest pain. You'd be saying, all right, have you ever had this chest pain before? This chest pain, right? I'm saying this. Have you ever had this condition or this chest pain before? Because we're talking about chest pain here, so chest pain before. Then, are you diagnosed with any medical condition in the past? There are 5 to 6 conditions that you need to definitely ask. That is number 1, diabetes mellitus, hypertension. Okay, diabetes mellitus, hypertension, right? What else is there? What else is there? Thyroid disease, any cholesterol problem, right? Any MI or any stroke. These are 5 to 6 diseases that you definitely need to ask about when you're dealing with a person who's coming with a chest pain and you're asking their past medical history, all right? Then you have to do your DASA, all right? What is DASA? DASA is, as I told earlier, this is your diet, your exercise, right? This is your diet, your exercise, okay? All right, your diet and your exercise. All right, your diet, your exercise, this is very, very important. Your diet, your exercise, your smoking, your alcohol. And if you're thinking of infective endocarditis, because that could happen, ask of IV drug abuse. Very, very important for you to ask that. All right. Then if it is a female, you ask about P1, P4. What is that? That is, first you're going to say, I'm sorry, but you have to signpost here for your DASA and your IV drug abuse, very important. And then you have to ask your P4, which is ask her if she's pregnant. If that's a female between the age of, she's in the reproductive years, ask about pregnancy, ask about pills, ask about pap smear, and ask about the 4th thing, which is period. That comes on the top, by the way. So period, pills, pap smear, pregnant, right? This is very important if you're dealing with a female. Then you have to think of meftosa. What is meftosa? Meftosa is your medication. Are you taking any medication? Right. By the way, when you're talking about the past medical history, you have to ask, are you taking any medication for that? So are you taking any medication other than the ones that you're taking for your past medical history? Right. For example, she said, I'm having diabetes. So you say, all right, are you taking any medication for things other than diabetes? Right, the patient would be like, maybe over the counter. Then you have to always exclude allergy. Any kind of station, always exclude allergy. Because if you don't ask that, then you're not being a safe doctor. And that's the main thing that we're doing here, being a safe doctor. Then family history is very, very important. You ask them, is there anybody in your family who's got such condition? All right, that's very, very important. Then we talk about so in family history, very, very important to us. Then travel history, because we were thinking of pulmonary embolism, right guys? Pulmonary embolism. Then O is for what? O is for what? Occupation. Occupation is very, very important, right? What is it that you do? What is it that you do? Occupation. Social history. If the patient's having a pain for a long, long time, you need to ask psychosocial history, right? So if a person comes in with a pain, any kind of pain or any kind of symptom, for more than 3 weeks, you need to ask psychosocial questions, which are 5 questions. Is this, or 4 questions, is this affecting your life? Is this affecting your life? And if that is affecting your life, how do you cope up with it? How do you cope up with it? All right. And if it is affecting your life, and if it is, if you're coping up in a bad way, do you work? What is that you do? If you do something, is it affecting your job? Right? And because it has been there for 3 weeks, which is a long, long period, is this affecting your mood in any way? How do you feel these days? Right? Very important. All right? Okay. After you're done with your DD's portion, you need to ask that, is there anything that worries you? Now, you see, I told you that in the beginning of the of your consultation, when you're done with your DDs and you've asked almost everything and you still don't have the diagnosis, right? So I said that in 120 minutes, in the 120 seconds, like the 2 minutes, you should have a diagnosis in your head. If you don't have that, then to help yourself, ask them, is there anything that worries you? Are you concerned about anything in particular? Going back, guys, are you concerned about anything in particular? And they say, doctor, well, I'm worried about heart attack. So you have to try and see, and you have to exclude that as you move along, because that is his concern. You need to address that. Okay, so P1, P2, P3, P4, meftosa. After that, before you go for examination, ask them, is there anything in particular that you expect from us today? What do you want us to do? Do you want us to give you a CT scan or so? You know, first of all, as a junior doctor, you're trying to not do that. But if you do, you have to ask them that, are you anything that is, if you're expecting today, then you do the examination. In examination, you're going to be doing the general physical examination, the observations, very, very important, right? Observations, which includes your heart rate, your respiratory rate, right? Heart rate, your respiratory rate, your temperature, your pulse, right? That's the same as heart rate. Blood pressure, very important. Chest examination, very important in particular. You're going to say, I'm listening to your heart. I'll be checking you from head to toe, which is general physical examination. And after that, you have to take the labs. Now, that depends if you are in the accident emergency. If you are in the accident emergency, you can do the labs. But in the GP surgery, it's very limited. And if a person's coming with an MI, because they can come with an MI in the GP surgery, and that is when, you know, you have to, when you come in with a person's coming with in the GP surgery with an MI, because they can come, right? They can come. You can't stop them. So if they do come, what would you do? What would you do is you'd refer them to the accident emergency immediately. Immediately, you'd refer them. All right, guys, so you'd refer them immediately there. And if they're in the accident emergency, you're going to go for, because you're dealing with heart, you're going to go with chest, with the ECG. So you're going to say, I'm going to do your heart tracing, right? I'm going to do your heart tracing or heart strip. I'm going to do some infection marker if the person's got the fever, okay? If not, then you're going to do chest markers or cardiac enzyme markers, right? So you're going to say, I'm going to do your cardiac enzymes, right? Just to see if this is something, if this pain is coming from the heart. All right, be very specific. Because if you are using medical jargon, first of all, you shouldn't, but if you are, please try and explain that. Okay? Explain that to the patient and make sure that the patient understands that. Okay? Make sure that the patient understands that. So, in the management, the first thing is, depending on what the patient's going through, admit. If the patient's got a stable angina, would you admit them? No. You would refer them to a cardiologist. But if he's having a chest pain, so bad that he cannot sit or talk and he's saying, doctor, do it hurriedly, I want to sit, I want to rest, I don't feel like talking, admit them. Admit them, because you're going to treat them with Mona, right? Which is what? Morphine for the pain, oxygen, nitrates, and A for what? Aspirin. You're going to give them aspirin for that, right? Nitroglycerin, oxygen, morphine, aspirin. This is for the chest pain, all right? And if a person's coming with an MI sort of thing, so you're going to repeat the ECG, you're going to repeat the enzymes, right? You're going to repeat them. This is very, very important for you to understand, because if it doesn't change, then it's fine. It's not an MI. But if it changes within 3 hours or so, it's in heart attack. After you've admitted them, after you've given them the symptomatic treatment, you go for the specialist treatment, which is angioplasty in this case, right? You're going to use a balloon or a tube, and you're going to make sure that they understand that. All right. Then after that, after you've done the admission, you've investigated them and all. But before you do the treatment, involve the senior, because you know your senior is your savior. That's what I call them. The seniors are your saviors in all situations, right? My seniors have always been my saviors. So your senior is always your savior. If you forget about something, if you feel like, I don't know, I don't remember this, I'm a junior doctor, involve your senior, because your senior is your savior. Okay, so after that, you've admitted them, you've involved the senior, you've done the labs. The next thing after the signs and symptoms is going for the referral and doing the angioplasty. Now, if they ask you, well, doctor, what's angioplasty? You're going to say, well, you know, we have a tube with a balloon and a camera, the tip of which will pass through the artery, which is blocked, and then the balloon would blow up. Right, so it'll just expand, like this is a balloon here, right? You're going to explain that, you know, there's going to be a tube, there's going to be a camera, the balloon's going to go inside your artery, which is clogged, all right? And then it will expand so that the clogged artery opens up, all right? And that's how it is, all right? The stent would be left there so that the artery remains patent and the blood keeps on flowing, right? Okay, after that, or the patient is done with all of that, and now they're saying that, you know, you need to follow this up, right? Because there could be a whole station where they want you to follow up the patient. Then you have to deal with DASA, right? So the patient in their... Now see, here's the thing. When you ask DASA, you cannot ask DASA, and you should not ask DASA in acute cases. Person's coming with a chest pain, 8 on 10, and you're saying, all right, tell me about your diet. The patient's going to be like, doctor, I'm going to kick you in your face. Don't ask me that question. Right? So you have to make sure you understand where you ask that question. So DASA should not be asked in acute cases, mostly because, you know, the diet, the exercise, the smoking and alcohol. Whenever you ask something in the history, right? Make sure you make up for it and use that in your management. So if you ask for exercise, if you're asking for drinking, which is alcohol, by the way, be very specific. If you're asking for sex, etc., for the sexual history, make sure you use it in your management. So you're going to be telling them, if they are not exercising, you're going to say, well, you know what, you need to exercise, all right? You need to make sure that you have a good diet. You need to make sure that you're not smoking. You have to make sure that you're not drinking alcohol, all right? After that, you're going to safety net them for their particular problems, and then you're going to send them home, and you're going to come call them back for your for a follow-up, which is also very important. But safety netting before that is very, very important. So you have to safety net always. See, 3 or 4 things for a station, all right? If you forget everything, first of all, you shouldn't, but if you forget everything, discover P1, do the DDs. If you forget, go and ask their concerns. Please make sure you ask about trauma. Please make sure you ask about flaws. All right. Make sure that you grade it. Make sure that you ask the past medical history, family history. All right. And then you ask and you signpost about things. Right after you've signpost about things, make sure that you giving them symptomatic treatment. Make sure that you want to be a safe doctor. Make sure you safety net. That's very important. Give them a tentative diagnosis. That is very important. So safety net, if you feel like you're having this pain again, please come back to us, talk to us. All right. And when the patient goes up on a follow-up, you're going to give them basic medications. What are basic medications? Beta blocker. Okay, that's your basic. A for aspirin. Okay, you're going to give them aspirin. Okay, or aspirin. All right. Then you're going to give them ACE inhibitor. Right, your ACE inhibitor, which is going to be enalapril or whatever, and S for statin. Many people are going to go for statin. Statin is also a station that we're going to talk about in the future, and C for clopidogrel. Right, so these are the medications that you're going to give them when a person comes in with a chest pain, and this is your whole chest pain. Now we're going to move and talk about what is specifically there in the chest pain. That's going to be a 5 or 4 minute video. So this is your 30-minute video. By the way, this is Dr.Hwd, and I hope you learned something today. Thank you.